floor is yours.
Morning, folks.
Do you need the mic?
I'm sorry?
Do you need the microphone?
Can you hear me in the back? Well, I have a different accent. I call it Indo-Cajun accent. This is my my personal struggle with neuroscience. I have had a brain injury to myself, and in the process of fixing it, I come across, and this is how everything evolved. And so pretty much when I'm going through this journey, I'm going to take you to neuroscience, how the whole memory development started even from beginning. And then where we are right now. And from there, you will learn how the memory is being processed and how it's being done. I want you guys to learn about the theory or how simple it is. Brain is very simple. Believe me, it works only one way. A straight way and crooked way, that's it. Right? So I call it Regain Memory 360 program. This program is developed to a complete healthy body, healthy mind. This is what it's all contains about. Now, as a disclaimer is obviously I'm the president of Neurology and Headache Center Inc. and CEO of the Regain Memory. Whatever I earn from my practice, 20% of the practice, I invest back into the research. And this is how we do the research pretty much. Can we go to the next slide, please? So we are clinical research-based practice. Our research are in headache, cognitive science, brain injury, dementia. That's what we do up there. We also have a small IRB in our center to do all this research. Now the story starts from here. A researcher, this is May 25th, 1992. Researcher, how long have you had a trouble remembering things? I don't know myself. I can't tell you because I don't remember. Researcher, well, do you think it's day, week, or months, how long it has been? Well, I can't put exactly when it happened, week, month, or year basis. But do you think it can be more than a year, or you have this problem going on? I think about that about a year more than I believe it I had. I just thought I am having myself, I had some surgery about it. So answers are non-specific. This is HM, which is a Henry Gustav Molaison. Now remember, all the neuroscience subjects and all the brain have been researched on a HM1. Now I think we are on HM7. Now, the story about him is that Henry Gustav Molaison, at the age of 7, he had a bicycle accident, and he was unconscious after when he hit the head with the ground, a forehead. After that, he had a surgery, and the surgery was done by Dr. William B. Scoville, who was a neurosurgeon. The reason he had to undergo surgery because he started having a frequent seizure. So they wanted to relieve the epilepsy or seizure. They wanted to take the area of the brain out, which is part of that was also temporal lobe and hippocampus. And when they took the hippocampus out, he had a problem with the memory. Dr. Brenda Milner was the doctor. She reported, she was a neuropsychologist, reported that he started having a problem of memory after taking out the hippocampus. In 1965, this went to a lawsuit. Now, this HM brain, which is a Molaison brain, is still kept in UC San Diego, where it is being sliced, and you can still go and see that. Now, Eric Richard Kandel, he is the master who showed the brain can reconnect back. He is a Nobel Prize winner. And I started following his work, and then this is where we are right now. He had published his article in 2009 in the Journal of Neuroscience telling that the synaptic connection can happen when you stimulate the brain with the electric connections. Next slide, please. So what he took was, he took a giant slug cell and he took out the 2 neurons connecting each other. And then, next slide, go ahead. And click on it one more time. No, next, go back, please. Yes, and this. Okay. All right, it's not letting me do that, so let me go back up here. It was, anyway. So it could show everything. So when he stimulated the electric current to the neuron multiple times, there was a new synapses. If you see up here, these new synapses developed after few stimulation. And he could show that first time in the living cell that neuron can reconnect itself. This is nothing but a neuroplasticity, now we call it. We did not know that this was a neuroplasticity that time. Let's go back, next slide, please. Now, there are few guys in this field. Karim Nader, he started working on his work, Dr. Kendall's work, and he showed that he can go and replace these connection with the more superimposed connection by also he can fix the PTSD, which is a post-traumatic stress disorder. And he started working on this in the McGraw-Hill University. Let's go to the next one. So the question is, how a person understands the world. What is cognition? Cognition is not an intelligence. Cognition is as simple as perception of hearing the phone, decision of making or answering the phone, the motor skill of lifting the phone, and language of the phone, the tone of the phone. Do you want to answer that phone? You know, is it robocall, or it's some other call you don't want to answer? Social skill, how you interpret the voice, you know, whether you want to go back and continue. So this is about cognition. Now, cognition is further subdivided into a complex attention, sustained attention, divided attention, selective attention, and processing speed. Executive functioning, planning, decision making, working memory, feedback, error correction, overriding, habits, inhibition, flexibility, learning memory, immediate recall, delayed recall, cued recall, recognition of memory, semantic, implicit learning, language, perceptual motor, and social cognition. So these are the part of the cognition we divide and we learn separately, we can test separately. Now, cognitive abilities are not fixed. We know with the age they decline, but they are not fixed. The bottom line here is the more we specialize, the least we use the brain. And that's why what happens here is the school system is that you learn math, science, history, English, everything all together. And later, once you specialize into that so that you have developed a perfect brain, and eventually you specialize into a one part so that now you have some part of the brain to use that. Let's go back to neuroplasticity. So nerve cell modeling, the human brain is continually altering its structure, cell number, circuit, and chemistry. It responds to a direct results of everything we experience, we think, and believe. This is called neuroplasticity. Neuroplasticity occurs in brain, obviously, you know, early in the age. 10 to 20 is when we are learning. School and college is fast. We are developing a new connection. The brain is also developing at the same time. That's the perfect time to learn. Now, in the case of a brain injury, we know some of them are physical therapists. When we do here physical therapy, what we do here is we do a collateral, circuit stimulation, and sometimes the other side of the brain takes over and people can walk again. You have seen that miracle happening again and again in your practice. During the adulthood, whenever new thing you learn or new memory you learn. Next slide, please. Now, this is a very interesting study. This came across is in the London taxi driver. And when they compared the brain of the London taxi driver and the London bus driver, they found the hippocampus of the London taxi driver were bigger than the bus driver. Can you tell me why? Yes, they have to negotiate and replan and take a different routes to go back there. That's why visual spatial is in hippocampus, basically. So that there was a big, so there are so many studies have been shown, even the people with the bilingual people have a more of the inferior parietal cortex bigger compared to the monolinguals. So this has been shown again and again in the brain. Let's go to the next slide, please. So how does the memory formation take place? Memory is a building block of intelligence. Now, without a memory in past, we cannot operate at present and learn the future. Depending on the ability of learn and retain in a short-term memory, which is called STM, through acoustic repetition, like, if you find a good, obviously nice-looking girl, she gives you a number. You do 1, 2, 3, same number. 1, 2, 3, repeat yourself. Sometimes you can associate, somebody and those things. That's the association memory with the visual memory. So this is how you make the short-term memory, and that short-term memory eventually converted into a long-term memory by a protein formation, a new protein synthesis, which is called the synaptic formation. So this is how the new memory is being developed. Now, assisted cognitive behavior training is a capable of repetitive stimulation of the brain with the visual, auditory, semantic, procedure memory, and we can develop a new connection. This is what is all about neuroplasticity. So on this basis, we went and further studied. Individualized neurocognitive rehabilitation can reverse cognitive and memory impairment irrespective of etiology. This was our pilot study we did with a very few patients. I think it was a 14 or 15 patients we did that in our own center. We had a brain lab. We got almost 31 patients, and out of that, I think 14 or, let's go to the next slide, please. And this was presented in American Academy of Neurology in 2015. This paper was. So in the 12 months period, we diagnosed 71 patients. Out of that, 21 patients were offered a customized cognitive rehabilitation based upon their specific deficit. 14 patients completed 20 sessions, 60 minutes twice a week for 3.6 months. After completion of the program, each patient, we administered the same WMS, which is a visual memory scale, which is a standardized cognitive testing. We do that. So when we did that, we found, let's go back demographic errors. No, let's go back again. Thank you. So the age distribution of these 14 patients was between 21 and 78 years. 7 were the male and 6 were female. TBI was 8, traumatic brain injury. 3 were a CVA patient. 2 were a dementia patient. Now, 1 was a hypoxemic ischemic injury patient. Let's go to the next one, please. What we found here is this, that if you look at this pre-test MoCA score, which is AMI is auditory, visual, immediate memory recall, and delayed memory recall. This percentile is the most important, which tells you that at what level you are with the age group of your age group. So when we did it before the training and after the training, you see the difference in percentile, how much there was improvement. Almost less than 20 percentile, 80 percentile in these 14 patients. Now, this is what we took a couple of patients out of this, and we showed that patient A on a WMS, this is how we score that. This is actual score of the patient. This is the normal average group. So before the training, the patient was here. After the training, you see that patient was on pretty much advanced. So this is the improvement we could do in first patient. Now let's go to the next. The second patient, we saw that he was all bottom line up here. Obviously, when you see this flat, this patient was, the other was TBI, this was the dementia patient. All low, below the average, much below the average. He was at the average level when we did that training. So our first patient was a brain injury from the Barksdale Air Force Base. He was a B-52 bomber pilot. He went back to, in fact, flying plane. He was supposed to be boarded, medically boarded. He was not supposed to. He was getting out. They sent me to take care of this patient, so we took care of him pretty well. The second patient, which was still dementia, he was showing a good improvement. We sent him, let's go back to, he was enrolled back to the Regain Memory program. The second one was. Now, so individualized neurocognitive rehab, conclusion of the study was cognitive remediation and neuroplasticity is independent of age. We can train these brains in the mild to moderate impairment. And what we have to do is we have to go and tailor supervised therapy can make those changes happen, which is called neuroplasticity. Now, our pilot study was limited by a strength and control next. So, human factor, cognitive training inconsistency. You know, when we started doing it, we didn't have nobody to train me how to do these things. We did not know about these things. I'm talking about this we did 4 years ago, or almost 5 years ago now. So nobody knew how to train this brain, how to make sure that everybody does the same way and train about it. Now, selection of a training program, how to select this program and train these people, what kind of programs are available. The patient's sleep deprivation, underlying psychosocial stress or limitation of availability of these programs, patient compliance. What we came across was very interesting was ecological or error bias. What is ecological bias is, you know, we have never been exposed to the video games. I'm talking about my generation. I don't know about you guys. So I've never played that. If you give me a press some button and keep on pressing, doesn't make a sense to me. And you know, I can't go through that. So that's a different one. Other thing is that a real object and real subjects is what when you use that, a real stuff to train the brain, then the association and that synaptic association is better. That's what we learned from this. Next, let's go to the next one. So Regain Memory 360 enrollment, patient population, you know, TBI, mild to moderate dementia, vascular dementia, hypoxic ischemic brain injury, multiple sclerosis, stroke, CVA, diabetes, and lupus. You know, can you tell me what is the most common cause of memory loss in young patients? Yes, trauma, but other than a trauma. In medical cause.
Drugs.
Yeah, obviously drug is another one. But the very simple things, what I see in my office, no drug seeker comes to my office and say, fix my brain. They come for that, give me more drug. So the most I'm seeing, and it's very amazed, that I've been seeing here is a mixed connective tissue disorder, which is not full-blown lupus. I'm seeing that age of 30, 35. These are the mostly females that are coming to me. I'm seeing more in my office, they are coming with diabetes, uncontrolled diabetes. You know, they have a type 1 diabetes, young patients, they're coming to me, they have a problem with memory. Okay, so these are the people, and they are early, you know, very early they go back into this nursing homes because of the cognitive problem. You know, I had a school teacher, she was only 39, and she could not teach. In fact, she was a part of this study, and we have sent back to her to go back to the teaching again. I had a librarian, age 50. She could not remember. She worked 30 years in the same library, and she couldn't remember where the bookshelf and those things, where the things are. We trained back to her. She went back to the job. There was a lot of other problem after that happened with her. Anyway, let's go back to the initial work of the patient. So this Regain Memory 360 program is not possible with, I cannot do it alone. You know, I need angels like you, because it has to be a multidisciplinary approach. You know, we need everybody out here to do this up here. So what happens is the patient comes to me first, or any physician. We go and, neurological evaluation, screening depression, anxiety, screening for a sleep problem, lab test, cognitive test, EEG if there is anything abnormality in the brain. Sometimes we can synchronize the brain by RTMS, repetitive transcranial magnetic stimulation. How many people know what is RTMS or TMS? Yeah, you know, last 6 years I have been doing a RTMS in my office. very first to do event for the memory and cognition in the country. I have been doing it. And how many patients, I call it simple, I reboot the brain and resynchronize the brain, and the brain goes normal. And I have few of the patients who have a brain injury, they come every 6 months to a year, and I do that. And they are functioning. Some of them are attorneys, and some of them are working in this community. So, our first study was very small. It was 14 patients. We wanted to do a further study. So we went and did online cognitive therapy in patients with the memory loss. By this time, we realized that in our office, we cannot bring the whole Walmart, or we cannot bring the whole world in our office and train the brain. That was what we had, was ecological bias. Now, to do this, we went and further studied 9 TBI patients, and this time we wanted to go and see more dementia patients, how we can change that. Let's go to the next slide. So the average time trained was 18.5 hours in 3 months. We did that on these patients. Now if you see the visual, the final score was all the p-value was very significant. This showed a significant improvement at the end of 3 months. 38.3% increase in cognitive domain with the 46% in executive memory. Now, this is how, when you go back and see, let's go, it shows the next one pretty good. Next slide. Next slide. Yes. Yes. So, if you see the final score, this is the initial score, the orange one. The purple is the final score. The visual, you see the 90 from 40 double almost, 30 almost 60. 80. So it was all doubled in the training process. But again, this was very supervised. So again, we had a limitation for this study. The reason was why. No exercise monitoring, no sleep monitoring, no supervised training with the compliance, because these guys were doing online cognitive their own. And in fact, they were almost like a total 48 patients were enrolled in this program. Only 25 graduated, 50%, because the compliance was a big issue. And so we were not able to monitor the vital sign. Dropout of the cognitive therapy was very common. So answer to all above was home health multidisciplinary delivery system, like you guys are out here, can help us effective monitoring and cognitive therapy program with technology and record compliance. If you can help us, we can make the changes together. Now, Regain Memory 360 is the answer to a traumatic brain injury, CVA, and dementia. Let's go to the next one. Do you guys have any question? No?
So the actual training is a series of games or questions and answers or online?
Yeah, let me answer. Let me just pull that. Okay, cognitive training, testing information. Okay. So the question is, what is Regain Memory 360 program? So Regain Memory 360 program is, what we have done is everyday object in the visual, auditory, whatever you see around everything, we have put in computer. These are questions, these are the object, these are actual sound, these are actual things what we do in routine. Everything is out there. What we do is we isolate, we test your brain. After testing the patient brain, we find out that these circuits in the brain are not working. And once these circuits are not working, then we design the brain accordingly. Do you know what is the most difficult part of training the brain for elderly people or people with dementia? What is the most difficult cognitive challenge we have?
getting them to focus?
I'm sorry?
Focus?
Yes, attention.
Yeah.
Yes. So this is a big challenge. So what happens here is when we are training the brain, we will go slowly and see how we can increase the attention span. And once we can increase the attention span, we can pretty much start training the brain. So this is all, everything is addressed in this program. But again, you have to understand that only a healthy body can have a healthy brain. Now the brain has to ready to learn. What we do here is we do the lab test. We do the neurochemical balance in the body to maintain that. We make sure that they have a physical exercise. When we did that study on ourselves, we found that the people who were mobile, who were actively moving around, had the maximum benefit. And so there was a paper which was published in JAMA, which was the study was done, I think, by a Yale group of physicians in up north. They did 11 patients exactly like me. But what they did was they also had a controlled exercise program along with that. When they did that, the study was remarkable. In the moderate dementia patient population, the recovery was pretty good. So there has been a lot of studies have come out and supported this. Now, let's go to the next slide here, please. Next slide, we'll skip these. Yes. So let's go and talk about some memory testing. MMSE, you guys know mini mental status examination, right? So Falstein test is also called. It was developed in 1975, introduced by a Falstein, and it went out of the because the way it was scoring and the way it was this MMSE was designed. Although it was able to do attention, recall, language, ability to simple command, but it did not actually translate into the actual numbers. So what happened is, let's go to the next one. So the mini mental status examination detection was by a Cochrane study. They went and did all the study, and they found that it was not significant enough to detect MCI or early dementia or dementia with the people. So this was not popular and among the our group. So we went and adopted MoCA, which is a Montreal Cognitive Assessment. You guys know about MoCA. I think we have given you MoCA on the paper, right? Also. So MoCA is designed by Dr. Nasruddin Jihad Nasruddin. He was from Montreal, Quebec. And this was designed for dementia. It was not designed for the TBI. But I think in 3 years ago, in 2015, I had presented this paper in front of Dr. Nasruddin, and I had challenged that why don't you give a statement that your MoCA is not good for the TBI patients, it's only good for the dementia, unless until you want to modify it, but he didn't do that. And I went all the way to Canada and challenged him, but it never happened. All right. So it was very good. The sensitivity was 90% and the specificity was 87% in the dementia patient. Very good compared to the MMSE, only a specificity of 10%. Now, this is the study which just got published. I came across this October 17th, 2018. Now, the reason why I want to bring this study for you guys, because this is the most recent, but this is the most effective to show why we want to use a MoCA. You guys come across the patient with a stroke every day in your life, and that's what you work on most of the time. Now, the stroke patient, this study was done by 274 patients in Germany and France, had a stroke, and these were given within a week Montreal Cognitive Assessment, MoCA. Now, they were divided into two groups. One group had a normal MoCA and one group had an abnormal MoCA, which is anything less than 26. So they found that after they went back and repeat on the 6 months and 3 year the MoCA test, and they found that after 3 years, the survival rate of an abnormal MoCA with the stroke patient was 83% versus 97% with the normal MoCA score. So just think that how important it is to save a life eventually in long term. If we understand that and we start working on a cognition, we can change a lot. Now, so MoCA, as you know, I just copied and I gave it to you. It's a free tool, pretty much. Whenever you go and see a patient, you just go up there and give a patient. It takes 5-10 minutes for the screen to go. You know where we are, how the patient is going to respond with that. Now, MoCA is also very sensitive as to detecting a brain dysfunction. By a pattern of the test score, you can also, I did a lot of study on this and I presented everywhere on MoCA. And we can, in fact, I did a MoCA my recent study was just, I presented in October of this year in the ACRM on NFL patients. So yeah, 100 NFL patients, MoCA. So it's ideal for a screening patient with the diabetes, lupus, autoimmune, kidney failure, early memory problem. MoCA should be given as an initial intake by a nurse, very first visit, at the end of, and then at the end of 4 months also it should be given. Now this is what we are talking about is the study which I did, I presented in 2015 on the TBI patients. One thing I just want to, you to know about this is that the patients who came after the concussion head injury, they were only 22% of the patient, only 22% of the patient knew that they had a cognitive impairment. 88% of the patient did not know that they had a cognitive impairment when they came to me after the brain injury. Let's go to the next one. So again, if you go back, the three things are more in the TBI patient or brain injury is delayed recall, visual, spatial, and attention. These are the three. If you put these three together, most of the people with a concussion head injury, the delayed recall is the most specific. That's what I'm trying to tell you. Yes. Let's go to the next one. Again, if you go back again, you see this major impairment in these three domains. Orientation is almost every time is normal. Let's go to the next one. We went and further tested the MoCA with the WMS and compared, and we found that MoCA was 87.7% sensitive, pretty much same as the Dr. Nasruddin recommended that in the brain injury. But when we took out the orientation, it was 90%. Let's go over the next one. And we found also there was a specific pattern in the brain injury compared to the dementia patient. Now let's go to the next step. If you see this here, the AMI, which is auditory, visual, and delayed recall, we found that there was this pattern, a dip pattern. We saw that in the brain injury, but in the dementia patient, we saw a flat line where the auditory, visual, and dementia, because everywhere the brain is affected, we saw the same flat line. This is what we are trying to report that. Let's go to the next one here. Now, question is, how we want to do that, how do you want to test the brain? Because training you guys to do extensive cognitive testing is not easy. Okay, so we came out with a tablet tool which is called DMAC, which is a dynamic mobile assessment of cognition. MoCA is equally good. So DMAC is developed after extensive research as a diagnostic screening tool for prognostic tool. Now DMAC can develop, it takes a 30-question task, and its accuracy is pretty good. It also detects disinhibition, memory, numerical memory, and speed, processing speed of the brain. Let's go to the next one. So DMAC is visual, immediate auditory, delayed recall, attention, executive, disinhibition, brain processing time, numerical memory. And we also presented this DMAC, the previous version, which used to call a BICS in AMIA, American Medical Informatics Association, in 2014 in San Francisco. We presented this study up there about this test. And it came out to be a very good test. But the reason I developed this test was to plan for the cognitive therapy, how to plan, how to make it simple, so that an average person like who is not trained neuropsychologist can also able to plan this and say, look, you need this training. Okay, here you need a help. Let's go to the next one. So this is a DMAC study we are talking about again. And when we did the study, we found that p-value was significant, how to detect the injury in this patient's pattern. Let's go to the next one. Now, the limitation is, anytime when you give a patient cognitive test, you have to make sure that he has slept well. Otherwise, overnight insomnia, there's an underlying depression, anxiety, and sleep apnea. How many people know what's called pseudo-dementia? What's pseudo dementia? Anybody?
It marks the symptoms, but you don't really have the diagnosis.
No, the pseudo dementia is a dementia in the people who have a depression. Simple. So what happens is in the people with the depression, when they are depressed, their attention span and is low. And that's why they have a pseudo dementia. You fix the depression, they're back to normal. It's as simple as it is. All right. So now medication, psychomotor slowing, and then any kind of medication. And after the TBI and the stroke, unless until you're trying to figure out what's happening now. So go to the next one, please. Yes, this is how the DMAC scores. This is a very important part of that. This is what you're going to see every time when you do a DMAC testing on the patient. Now, this is only possible in, the DMAC is only possible in mild to moderate dementia. The people who are still in a senior living center or the people who are living at home. It's not possible in the people who are in the nursing home, obviously, which is severe dementia, this test. When you see this score, we also give that, this is a percent is 53, 63, 63. So when you see this, anything above 80 is I consider as normal based on the studies. So anything above 80 is, when you see the attention and executive here is 40. So this is how this is scored. When it gives you a score, pretty much based on this scoring, we can plan and we can pick up this and we can say, look, we need to work on this. And there is a formula I can give you also after that, how to train the brain. Let's go to the next one, please. So interpretation and planning. Impairment in a visual or auditory memory below 50% triggers early intervention. But anyway, anything less than 80%, we want to do that because to improve that. Attention domain exercise should be always added. As increases the attention will increase the exercise tolerance in visual and auditory domain. And that's how the score increases. Always add a numerical or 1 or 2 game type module to increase the compliance. Let's go. So now there is a new term I'm throwing, LICA. I named this my brain training, my brainchild, LICA, which is a life integrated computerized cognitive application. Okay, so LICA is the training should be follow a rule of 3. The training should involve 3 exercise modules from a 3 different cognitive domain, always 1 module of attention, plus 4 delayed recall exercise, and at the end of executive domain, only 1 exercise module. From a 9 exercise module, you should select 4 delayed recall. I'll explain you what delayed recall is. And total exercise module should be total 14. And let's go to the next slide. Okay, now this is an intake questionnaire for planning, know your brain, a patient's brain. You want to know the patient, how his brain works, what he has been exposed to, what he knows. If you know what he knows and start from there, it becomes easy. If you know that what he does not know, when you start from there, the life is difficult from there. It's simple. So what he's exposed to is very important. And that's how this questionnaire can tell me exactly what kind of music likes, what kind of game he played, what was his GPA score, what was his baseline, which is called cognitive reserve. This also gives me a lot of idea about what his interest. Based on this, you can pick and choose those brain exercises. That's the whole idea is. Let's go to the next one. Okay, so any questions so far? I have 10 more minutes, right? I can go? Yeah. So, any questions? Can I get a little water, please? Thank you. Now, this is a little technical information about a Regain Memory 360 program. Thank you. It's a fire-to-wire campaign. Let's go to the next one. So yeah, I have a small limo called Regain Memory too. So let's go to, so technical detail. Patient resources, Regain Memory 360 Physician Monitor Cognitive Therapy Program. This is, in fact, when you guys in field are training these patients, I can see, log on and I can see how the patient is doing by graph from my office. How many times you guys went, what your patient did, what is the score, whether he is going up, going down. We can also intervene and call you, look, we need to do this thing to change the plan. So it's not monitored at your level. You can also monitor your level, and you can print the report and you can put in the chart so that if the Medicare ever audits, we have that information that, look, we have done these things. But as a physician, I can go and see, oh, how this patient doing. It's a monitor program. Now, it's a multidisciplinary approach. Physician screening establish the diagnosis. Physician optimize for the body, brain health. Speech therapy test the brain. Home health monitor the compliance for training. Cognitive therapy, brain exercise and training. Nurse monitor the vital and brain health. Vital tracker, which is important. Each of our patients will also have a kind of a cheap version of a Fitbit. So we can track how many steps they take, what kind of sleep they're having. If they are not, then we can go ahead and intervene that. Now, Leica can quantify and monitor the training. So this whole thing is a Regain Memory 360. Next. No, I'm sorry. Let's go back. Let's go back. So a component of our RM360 is DMAC, we talked about. Question, if the patient cannot or is not able to take a DMAC test. Yes, anytime a Montreal Cognitive Assessment value more than 20 out of 30 score are able to take the test. But it's still not, we can just rely MoCA as a scoring thing, and we can still train the brain. Because remember, Leica has an inbuilt scoring system too, so we can monitor the progress there too. Let's go to the next one. Okay, now what we need for this is an Android tablet. That's not your headache, I think it's Patrick's headache. All right. Now, it runs on a Google Chrome, only recommended browser to run the program. Display screen resolution is this. Online training, you need an internet connection for that. So yeah, good connection. Next. Audio-visual cognitive task assessment tool. Let's go skip that. We talked about DMAC. Skip that, please. Okay. So Leica, most of the online brain games only stimulate the visual and motor response. How many people have played Lumosity? Okay. So every time I play with my son, I lose. The reason is he does not have a disinhibition, you know. He keeps on pressing. The more you press, the more score you gain. Because now it's a visual and motor response. There's no use of brain. And for us, we have been trained to read, see, and then press. So it's a different generation of that. Okay, so memory loss is a silent disease. So you do not use it, you lose it. Our research shows that patients with a stroke, dementia, TBI, you know, they will, as well as the problem of abstract thinking, we can improve by Leica. This is what we have done here. So Leica brings the world to you. We can, just on the tablet, we have the whole world, we bring it to you, pretty much. Let's go to the next one. Again, it can run on the Windows 7 also. It can run on even on cell phone. But again, for these patients, it's not possible, small this thing. So let's go to the next one. Now, Leica helps to reintegrate the patient into a normal life activity. We have something called ACT, A-C-T. If you go to the patient's house and, you know, like his daily chore, where you have just as simple as sorting the clothes. Let's put for the laundry, let's put the white clothes separately, color clothes separately, and you can see that and you can score that also in the Leica. That, look, he didn't make a mistake, he made the mistake. So those things also we can, because these are the simple thing what cognition is about. Cognition is not about rocket science. Scientist. All right. So Leica patients are able to think through a situation, safety, comfort of their own home. If you put them into a braining center and then what happened? They get overwhelmed. If you take out that patient with the dementia from his environment, they are not comfortable. They don't learn. If you take this over there, it's simple for them in the same environment. Let's go to the next one. It has almost 150 brain training exercises with the different level. Now it is coded into a different color level, is green, yellow, and red. Obviously, the green color is the basic for the moderate to severe dementia. The most easy is for the most severe dementia. The yellow is for the mid-level, and the red is for the advanced with the people who, our level, we want to sharpen our brain. Next to the next one. So this is how the Leica looks like when you go online on the computer. Pretty much, it's very simple to play this game. It's very simple. There's not much of distraction. Down here is the biometric tracker. Here, this program is, obviously is limitation. Patrick has given only 1 hour to finish this, so I cannot show you everything on this. But let's go to the next one. This is how the green, yellow is these games are. This is a simple trail making test. You must know about these things. Simple up there. Patient just touches those things. So from odd number, even number. Go to the next one, please. Now this is attention. Like we are using the real life stuff. We have seen this. Some of the animals, some of the things we. So now if you see up here is DR. What happens here is once you attempt that, after 20 minutes, there is a delayed recall here that gets activated. It says, look, you have already attempted this, and go back and answer again. This is the most important what we are losing. In the dementia, we are losing in the brain injury, the delayed recall, which is called short-term memory loss. Now, this is how I can train the brain delayed recall, and we have done a lot of work with that, and it works. We know that. Let's go to the next one. Again, the rule of 3 we talked about, how to train the brain. We will talk more when we train you guys training. Let's go to the next one. Now, biometrics, how much time it takes for you to train these patients, how much time you spent. So biometrics is you're going to go back and check his heart rate. Obviously, anytime the therapist is make sure that you take the blood pressure and pulse. And even I want you to carry pulse ox and see whether is enough oxygenated in the brain. So biometrics, 2 to 3 minutes. Let me ask you this. A question up there is, when you guys go and attend a patient who is a smoker, and if you have a pulse ox, if he's a frequent smoker, obviously whenever he smokes, his pulse ox goes down. But that's a false indicator, you know that. The pulse ox is actually a false indicator in the smoker, pretty much is. So you have to watch that. Is that pretty accurate? Is not accurate, but still we can have what's going on. Is each exercise module is 2 to 3 minutes. 14 exercise module multiplied by 3 minutes is 42 minutes of total training time. If you have a time left, you want to spend an hour, 20 minutes, you can do some leg exercise, walking with the patient, and always talk current topics, what is going on about the current grandchildren or great-grandchildren, anything new, what is going on happening. This is important. Never do a baby talk with the patient with the dementia. Never do that. Let's go to the next one. This is, how many people are nurses here? Boy, okay, all right. So when is you call the nurse or when you call a physician to intervene when the brain training is going on? Okay. So report not sleeping well on a tracker or drowsy during the day. When you're trying to give him training, he's sleepy. That means suspect medications. Is he taking is too much? Or there's a UTI or sleep deprivation. You need to call the nurse practitioner or call this thing or make a go back and revisit that. Now, if the patient is irritable, hostile, and he is anxious, you can't train the brain. So call the doctor again, send the patient back to the nurse practitioner. Look, this is not happening. Check for the UTI or suspect sleep disruption. Patient is having excessive crying and no interest. He's just motivated, just sitting. He's not responding anything. Again, suspect depression and sleep deprivation. Patient is dizzy, decrease or no appetite. Low blood pressure, suspect UTI, check. Changes of a mental status, a slurry speech, off balance, facial droop, weakness. Anytime is something, obviously, that's a CVA stroke, first to rule out. So this is all about the program. The next, when we will meet, is I'm going to train you guys on the program by itself. It's very simple program is designed. Just few touch. We're going to show you how to give the DMAC test. We're going to do a MOCA once again with our. If you guys have a MOCA, I've given you the form. I want you to go and practice on one of